I'm going to go ahead and start off our session. I'm Miriam Bornhorst from Ann and Robert Lurie Children's Hospital in Chicago. I used to be here for about 10 years too, so some of you may also know me from this area. But we are going to be talking today about some of the radiology sort of issues and questions and things that come up within neurofibromatosis. So thinking about neurofibromatosis type 1, the NF2 associated schwannomatosis, as well as other schwannomatosis. We're going to try and make this as broad as possible. I apologize for the lack of seats. There are a few up here. I see a couple scattered seats there too. So feel free to sit down if you can. If you have an empty seat next to you, if you want to flag people too. I guess the room is a little smaller than we expected it to be. So I want to start off this session. I'm really excited today to have three amazing people with me in this session. And what our goal is going to be is to kind of give you a little bit of education about sort of what we do with radiology imaging. The first talk is going to focus mostly on NF1 related imaging. But then we're going to go into a panel discussion to talk a little bit more about imaging sort of within all of the different syndromes. And then we're going to go into a little bit of discussion, because this comes up quite regularly, about contrast exposure or sort of the sedation and frequent imaging, and what do we need to think about there as well. So we also have a neuroradiologist with us today who's going to be able to help give us some sort of education on that aspect. So I want to start it off with a poll, just because I want to see where everybody in the room is, and just to give us an idea of, what people are coming in with in terms of your experiences with radiology imaging. And so the first poll on the screen here, and you can take your phones and scan the barcode there, and then it'll give you the option to answer the questions on the code or on the poll. And the first one here is, approximately how many MRIs or other types of radiology scans have you or your child had? And this is going to go anywhere from none to more than 25. So just to get an idea of what people in this room have had in terms of the number of imaging.
Yeah, that's the question.
Wow. It's impressive. All right. Well, we have a lot of people who've had a lot of imaging. So, like the comment up here was, it's not unexpected. All right. Give it one more second, and then we can.
I feel like I'm watching the Kentucky Derby all the time.
Yeah. All right. Let's move to our second poll question. How would you best describe you or your child's NF center provider's approach to imaging? So this is also something that's done a little bit differently, especially in the United States. Imaging based on symptoms, screening imaging, such as an MRI to screen for a glioma and then focused on symptoms, I'm not sure, or something else. So it looks like screening is actually kind of up in the top there, and then based on symptoms, followed by just based on symptoms, and then the other two. Interesting. All right, great. The third poll question. How do you receive results from your imaging? And then I think there should be an option for you to select anything that applies, but someone from the provider's office will call or message you with results after the imaging. A scheduled clinic visit after the imaging where you get to see images and review results. I read the report online. Other, or my child has not had imaging done yet.
It does just allow you to pick one.
Only one? Okay, sorry guys. Pick the one that's most relevant then. What is the most? All right, so it looks like we have someone from the clinic, or a scheduled clinic visit after imaging is the top option here, the top selection here. That's great. All right, and then we're going to move to the next one. This is more based on how you feel about imaging. So how comfortable do you feel reading the imaging reports? So not at all comfortable. It's like another language. I get the gist of what the report is saying, but still need help understanding the results. very comfortable. It's nice to meet with my doctor after getting the imaging done, but I have a good idea of how things are going by reading the file report. My child has not had imaging done yet. All right. Oh, that's great. Look, we have a lot of people who get the gist. I like that. And then very comfortable. We have a lot of people who feel very comfortable too. Nice. Good. That means that you're getting good education in your doctor's offices. It's really good to see that. All right. And then the last question, and then we're going to move to our talk. How would you best describe how you or your child feels when asked to have imaging done? And then this is going to be, it was supposed to be select any that apply, but just select the one that is most relevant to you or your child. Nervous, relieved, scared, no different. It's just part of my routine, or other. Okay. Wow. Yeah. Wow. That sort of reflects the number of images that people in this room have had done, I think.
Anybody have over 56 MRIs? I've had 56.
56? Wow.
Beat that.
I can't. Wow. Impressive. All right. So the next part of our session, I am very honored to invite Dr. Amedeo Azizi to come up here and talk a little bit about the European guidelines for radiological imaging. It seems kind of odd for us to be talking here about European guidelines, but part of the reason we're doing this is because I think they're really great guidelines for us to think about, but also because in the United States, as many of you know, we don't actually have guidelines for everything quite yet. So the European side has actually been pushing guidelines a little bit more so than we have. So I think it's a great way for us to see sort of what is being done in another area. So thank you so much for coming, and I'm going to slip over here and let you talk.
Thank you so much. I'm really honored to be able to speak here. So my name is Amedeo Azizi. I'm a pediatric neuro-oncologist in Vienna, Austria, in Europe. And I'm the head of the pediatric neurofibromatosis clinic in my center. So these are my disclosures, but there are no relevant disclosures regarding the topic of this session. Are there guidelines for surveillance? Well, the answer is yes, there are quite a few, and it's a bit difficult to really see your way through that. I wanted to mention this French guideline from 2020 because they really went through all the literature there is in the last decades to really find a way through all that and give some guidance. And then there is this guidance, a guideline I will talk about today. This is a guideline that we drafted in the European effort and that was published in 2023. And this specifically topic, there's a specific topic of tumor management guidelines and not kind of overspanning neurofibromatosis guidelines. What are ERNs? These are European reference networks. They have been created by the European Union in order to bring centers in Europe together for rare disease. There are different networks. One of them is ERN Genturis. Genturis stands for Genetic Tumor Risk Syndromes. And so far, we have drafted guidelines not only for neurofibromatosis type 1, but also, for example, Leaf-Romania, TP53, TP10, and recently also the constitutional mismatch repair gene deficiency. So there is an effort of unifying the approach, which is somewhat more difficult in Europe because we have so many countries, so many different health systems, and still we wanted to have kind of at least a red line that we could follow. So the question that we're asking for those guidelines, and I picked out those that are relevant for the session now, is in people with NF1, what imaging, screening, and surveillance is beneficial for detecting tumors? What is the method and interval of surveillance? And this is something that is novel in these guidelines and special to those compared to any other guidelines, is that we also had the aspect of the psychosocial impact and support that is needed for people undergoing surveillance. So there was a core writing group of which I had the privilege to be part. And these were formed by experts and patient representatives. Also, this was kind of a novel thing to have the patient representatives on board for drafting the guidelines. We performed the literature review, selected the literature, then wrote the recommendations, and then went through 3 rounds of consensus with European experts, a so-called Delphi consensus, if you've maybe heard about that. So there were multiple aspects and tumors that were looked at. I will focus on those that are written in black here, on the optic pathway glioma, the non-optic glioma, including also high-grade glioma, plexiform neurofibroma, then the MPNSTs, the malignant peripheral nerve sheath tumors, and then those tumors that have this name that I really can't pronounce, the atypical neurofibromatosis neoplasia with unknown biological potential. We used to call them atypical neurofibroma. Was more easy to pronounce, but anyway, so if I struggle pronouncing it, you know what I mean. And then last, I will talk a bit about breast cancer surveillance. So this is not about imaging, but the question was on how often should patients with NF1 being checked, and there was a minimum, because it might well be that an individual needs more than that. It should be a minimum of annually in children up to 10 years, once every 2 years in children older than 10, once every 3 years in adults, and during transition to adulthood, more frequent visits might be necessary. So, coming to the optic pathway glioma, the most important sentence is not about imaging. The most important sentence is that the clinical assessment for optic pathway glioma should take the form of the examination by a trained pediatric ophthalmologist or neuro-ophthalmologist or equivalent with experience in the assessment of NF1-related visual changes. So on the right side, I won't go to that every time, but you see the strength of the recommendation. Some are just weak, so it's just an expert opinion. Some are strong, and there's a lot of literature behind that. Regarding imaging for optic pathway glioma, imaging with MRI should be performed in people where ophthalmologic examination is suggestive of optic pathway glioma, or in children older than 2 years with repeated inconclusive or unreliable ophthalmological exam, for example, due to age or attention deficit. So we on purpose left a bit of flexibility here. So not to forbid to do screening, even if there are no acute signs of optic pathway glioma, but if you have the feeling that you just don't get the response from the ophthalmologist. Regarding the non-optic pathway glioma in children, routine diagnostic imaging screening is not indicated unless there is presence of symptoms. And then, of course, you should do screening. So I think the yellow bars went down a bit, but that should mean that once there are symptoms, you should do an imaging, but you shouldn't do screening imaging. Then regarding plexiform neurofibroma, I quickly go that there are many more recommendations in that set of guidelines, but of course I want to focus on them, on those that are actually essential for the session today. Imaging by whole body MRI to monitor plexiform neurofibromas should be performed at least at transition, and this is new. This is completely new in these guidelines, that there should be a whole body MRI screening at transition from childhood to adulthood to evaluate internal tumor burden as a predictor for malignant peripheral nerve sheath tumors, knowing that patients that have no signs of internal neurofibroma have a much lesser risk of developing MPNSTs than those that have a higher tumor burden internally. That does not mean that if a screening MRI doesn't show any signs of tumor, that this patient might not still develop MPNST, but the risk is so much less that you wouldn't rescreen. So whole body MRI assessment at higher frequency may be considered for patients at high risk of MPNSTs, and I'll go to that later on. And the frequency of repeat imaging should be determined on individual basis, meaning that if there are high risk patients, and I'll come to the high risk later, then you should perform more testing. In the absence of internal neurofibroma, I told you that you should only have clinical surveillance. On the other hand, for symptomatic plexiform neurofibromas, they require more monitoring because they might kind of transform into malignancy, into atypical or MPNST, and then PET imaging, FDG PET imaging, and preferable PET MRI because you don't have the CT part of it, or if not available, PET CT scan should be done together with a local MRI.
Would the tumors both be PET avid if they were, whether they were cancerous tumors or regular tumors?
Let me get back to that later on. Regarding the MPNSTs and ANUP-BP, so these are the high risk factors that we know about so far. Maybe there are others, but these are the ones that we know now. NF1 microdeletions affecting also the SAS12 gene, missense variants, these specific codons, previous atypical neurofibroma, high internal tumor load on whole body MRI, previous radiotherapy, which should be avoided unless you have a highly malignant tumor where radiation therapy is absolutely necessary, and if you have a relative with NF1 and an MPNST. So these are the ones that should receive more screening. But the most important thing still is the clinical assessment, is the tumor growth, mainly a rapid increase in size, is the pain, novel pain that has appeared over time, or change in pain, new motor deficits or sensory deficits, or the development of a hard nodule in a previously soft plexiform neurofibroma. And regarding the, so if you see those clinical signs, you should think about the risk of malignancy, and you should have a regional MRI and an FDG PET to be done. This is a very important sentence, not about imaging, but there is no place for watchful waiting in MPNSTs, and urgent surgical resection should be performed. So this is very important. So you cannot go into screening if you have the diagnosis or even the suspicion of an MPNST. If you cannot resect an atypical neurofibroma, for MPNSTs, you would even risk neurological damage to remove it. But if you think it might be an atypical neurofibroma, and the surgeon tells you, well, you cannot operate on it without neurological deficit, then you should have close monitoring every 6 months, and this should also include PET monitoring. Regarding breast cancer, there is a recommendation because we know that women above the age of 30 have a very elevated risk for breast cancer compared to the general population. An annual screening with breast MRI should be done if the Social Security pays for it. Otherwise, a screening by mammography is okay as well. And after the age of 50, you should continue with the normal screening guidelines. Why? Not because actually the risk of breast cancer lowers in the NF population, but it actually matches exactly the general population at the age of 50. So there's this excess risk is gone, and you just have the same risk as the general population. So what might the next steps in the future be? And this is not part of the guideline. I have to state that very clearly here. There are 2 papers I want to mention. One is from our group. We did FDG PET screening in asymptomatic patients, in children and young adults until the age of 25. And there is a large study that was published just last year from the French group who did PET MRI as a screening tool. And I want to go into that. So screening by FDG PET. So what is a PET? Well, no, it's not that kind of a plastic bottle. It's a positron emission tomography. So it's a nuclear medicine imaging tool. What does it do? It does detect metabolic activity rather than anatomical size or form or whatever. So how does it work? You use common biological substrates like sugar, like amino acids, and then bind to it a minimally radioactive substance, so-called tracer. And of course, if an organ needs more sugar, for example, this substance will accumulate there. And this can be detected by specialized cameras. And it's possible to combine this method with MRI or CT for the anatomical location. These are just a few studies looking at FDG PET, and this is one of those imagings from one of our patients. And what you can see here are these two hotspots with increased uptake. And actually, the one we were concerned about was that one here. We removed that. That was plexiform neurofibroma, whereas that one we didn't have on our radar was actually already a low-grade MPNST. That was removed before any symptoms occurred. This is my last slide for the French cohort. They were looking at 240 patients in between 2017 and 2021. So these are really recent data. And they included around 150 asymptomatic but at-risk patients. We've been talking about that before. And they could detect 8 MPNSTs, 6 atypical neurofibroma, 29 NOPP. And what is very important, that at the end of the study period, they had the same patients in there. The proportion of high-grade MPNST in screened individuals significantly decreased. So this is kind of interesting and might come into play for future screening protocols. So coming to my conclusions, and here you can, if you want to scan the QR code, you can directly go to the guidelines. Screening should follow evidence-based guidelines. The management should be done in a multidisciplinary fashion. Psychosocial support for patients and families should be offered. And well, this is my hospital as it used to be a few centuries back and as it is now. Thank you.
Thank you so much. So we're going to move into a little bit of a panel discussion related to that talk, and then we'll have another quick talk and then have another panel discussion, and then we'll make sure we grab some audience questions as well. Before we start, I do want each panelist here to just give a little bit of background on yourself, your experience, and why you are a part of the panel today. So I don't know if we want to start over here and move our way around.
Hi, can you hear me? Okay. My name is Shivani Ahlawat. I'm a radiologist at Johns Hopkins. I've been there for about 13 years, and I'm part of the comprehensive NF clinic. And we meet in a multidisciplinary fashion weekly every Friday morning.
May I ask the question?
Yeah.
What is the level of SAT in the PET scan?
Maybe we talk about the PETs later on, and we just finish our round here. So it's around 3.5, but I don't want to go too much.
Yep, that's good. All right.
Okay, so I'm Amedeo Azizi. You've heard from me before. So I'm a pediatric neuro-oncologist. My main focus is optic pathway glioma and imaging on plexiform neurofibroma regarding early detection of malignancies. But I'm a pediatrician, so yeah.
Great. And Heather? You should be able to just talk. You can just talk. Yep, just talk.
Just talk. Okay, I can just talk. I talk too much. My name is Heather. I am an NF2 patient, and I've actually learned recently that Shivani has been reviewing my MRIs for the 13 years that she's been at Johns Hopkins. And presumably someone else has been reviewing them for years prior. So I am a volunteer with the Children's Tumor Foundation Engage program, which is kind of how I managed to get myself up here. So I'm super excited. And if you see me walking around, feel free to ask me any questions. I'll talk to a wall if you ask me to.
Great, thank you. So I do want to just start it off with a question. Dr. Azizi, you gave a really good presentation on the European guidelines for neurofibromatosis. And then there are also guidelines for schwannomatosis that we didn't necessarily talk about today. It was presented a year or two ago. And so part of the reason we didn't re-present it is the guidelines are available via a video that you can watch from one of the prior CTF conferences. But I guess my question for you is, what changes have you seen over like the last 10, 15 years? And what do you expect to happen in the future, especially now that we have drugs available that can treat some of the tumors in NF1? We're working on drugs for NF2. And there's a lot of talk now about the prevention of tumors. So what do you expect to happen in the future with imaging?
Yeah, that's a very tricky question, isn't it? So what have I seen? I'm in the field for now 21 years, and I haven't seen as much progress as I would have liked to have seen. And as you are a pediatric neuro-oncologist yourself, you know that we have drugs for treating many of these tumors already. And for me, regarding low-grade glioma in children, for example, standard chemotherapy still remains the gold standard until proven otherwise. And we know that these the cure rates with low-grade glioma chemotherapy is better in patients with NF1 than without. And we know that we can have kind of the patient doesn't show any relapse in around 70% of cases after standard chemotherapy, whereas with the novel treatments like MEK inhibitors that have no licensing so far for optic pathway glioma or glioma in children or adults with NF1, to keep it that way, we see that after stopping those treatments, patients might show relapses maybe more often or regrowth more often than with standard chemotherapy. To cut it short, I think that screening is of value regarding optic pathway glioma because of the risk of visual deterioration. And if I say screening, I'm not specifically saying MRI screening here. You've heard about the guidelines. There are different approaches in different centers. There are studies pro-MRI screening, studies against MRI screening. There is this large ongoing natural history study by Mike Fisher and Rob Avery, who will at some point hopefully answer the question whether those, because centers enter their patients there that have MRI screening and those that have not, and maybe at some point we will see whether patients will profit from early diagnosis by MRI screening. I have to confess that at our center we do MRI screening. I know that in other centers they don't. So, but I'll stop there.
Great, thank you. And then Heather, I want to go to you next. So you've had a lot of MRIs in your lifetime, as many of the people in this room have had, and you've done an excellent job advocating for yourself in the healthcare system, advocating for your care. What advice would you give to other people with neurofibromatosis or schwannomatosis regarding how to work with their provider so that they feel comfortable getting the imaging done when this is needing, and in a way that is good for you or that works well for you?
Yeah, so I have had many MRIs, just like most of you have. And there was a period, I want to say about 10 years ago, where I felt really run down, really anxious, really stressed. And I think, most of us get to that point, at some point. And it was just too much for me at that point. I remember calling my doctor and saying, my head is hurting. I've got like 36,000 brain tumors. I know something is going on. My doctor saw me and she's like, it's anxiety. And I'm like, are you kidding? Really? So I think advocating for myself and working with my provider and really being open about everything that's going on in my life, not just looking at very specific spots on my brain, very specific spots on my spine, and saying, okay, this tumor we need to watch. No, it's really the whole thing. And you really need to be able to trust your doctor and say, look, my life is super stressful right now. My husband is waiting on a kidney transplant. I just lost my job. removing. My great aunt, twice removed, has cancer. There's so many things that we're all going through. Trust your doctor, talk to them, really advocate and say, okay, I need you to listen to me and hear everything going on. And honestly, if your doctor's not willing to do that, I hate to say it, start looking for a new doctor, because you're the one, you have to do it yourself sometimes. You're the one that knows how you feel. So tell someone that, and don't be afraid of it.
That's great. That's really, really great advice. Thank you. I want to move to you real quick, Dr. Ahlawat, and just ask you a question about we asked about the report and whether people are reading reports, but there are new laws now that require that these reports come out really as soon as the imaging is done. And a lot of families are seeing them before the doctors even are. So what advice would you give to patients and parents of neurofibromatosis, schwannomatosis, as they're reading over these reports, knowing that, again, they're reading it before, a lot of times we even are?
In this crowd, it seems like it's a very knowledgeable crowd. As we saw in the survey, they all seem to have a great gist of the report. But if there's ever a question, as Heather suggested, communicating with the provider, asking any questions, well, what does this line mean? And if they have a question, they can communicate with the radiologist. I'm often not the person you talk to directly, but I do see patients intermittently, and I do remember their names, and I remember Heather's. Just communicate if there is a question about a report, because you had the test and you should understand what the results mean.
Great. Thank you so much. And I do want to throw out there too that sometimes after re-reviewing the reports, clinicians can sometimes find that the results are maybe a little different than as it was presented. So keep that in mind as well. Sometimes the report sounds scarier than things really are. So, as you mentioned, always ask your physician if you have any questions.
May I add something?
Yeah, absolutely.
So I just wanted to add quickly to that the reports are available, and I've shown up in my doctor's office, and we actually look at the reports on my screen because they're not available on hers yet. But if you are in that bad place where you're super anxious and you've got too much going on, and it's just, don't look at them. Even though, it may pop up on your phone and say your reports are available, that doesn't mean you have to open it. Really, just ignore it for a while until you can say, I've got time to sit down and focus on this. Ignore it.
May I follow up on that?
It's okay.
Because I think this is very important. So we give our patients a follow-up to discuss the results. That shouldn't be too far away, of course. But in the meantime, while we get the report, we if there's anything that troubles us, we discuss it in our team, and then we come to the patient with an answer. And just, if we discuss a report and say, well, I have to go back to my colleagues and discuss it and see, and maybe we should do that other evening, whatever. So that's why we give those appointments. And yes, also in our country, in Austria, there is an electronic data system where those reports get online. I don't know about many patients that actually, or parents that actually go there to read them. It seems to be different here in the US. But I think that we give those follow-up visits for a reason, and in order to discuss it with the patients then, and so to keep them from being scared.
Yep. And I think that's really important. And on the poll, there were a few people that, I think it didn't allow you to select everything, but few people who had said that they don't necessarily have a follow-up after their imaging. And I would really say that you should advocate for that. If you have an MRI done, you should have an appointment shortly afterward to talk about the imaging, look at the pictures if you want to. That way you can ask your provider if you have any questions. Even if it's like everything looks normal MRI, sometimes it's nice still to just go and make sure that you can touch base with your provider and that they don't have anything to add to that.
I'd like to add to that.
Yeah.
My name's Dave. I have schwannomatosis.
Sorry, we're going to, just because there's people online,
yeah.
I need to make you use the microphone.
No problem. So my name's Dave. I have schwannomatosis. Obviously, ours is the rarest. There's 1 in 70,000. Me and Rebecca in here, we're the only two right now in this room, I think. Like I said, I've had like 56 MRIs. My first MRI that I had done, the doctor never got back to me. It was 2 months before the doctor got back to me. I didn't even know I had a tumor. I was complaining about sciatica. So I understand to ignore stuff like when you're already into it, but don't completely ignore it. Like, you have to follow up on stuff. I didn't expect 2 months later to call him up and he say, "Oh, you have a tumor in your spine. You have to hurry up and get in here." So you have to advocate for yourself. For when it comes to the MRI reports, I have a binder. I have a spreadsheet of all my MRIs, the dates, and I have all my MRI reports. So if I have to go back to them, or if the doctor needs to question them, they can look and see, how long, when this tumor grew from this date to this date. So I understand where you're coming from with the anxiety. Unfortunately for me, I don't have to worry about fortunately for me, I don't have to worry about the anxiety because I used to be a volunteer fireman. So I used to put air packs on and go in, confined spaces. So when I go to get an MRI, it's like I go in and I take a nap. After 56 times, it's not a big deal for me. And maybe it's a mindset. I know that mindfulness is stuff that we're learning, and Ethan's doing a thing at the end of the conference, and I did a thing with him with mindfulness, and doing your mindfulness stuff before you go in for your MRI. That's going to help you out get through that MRI. I've had 3 whole body MRIs. They're the longest. They take like hour to 2 hours. Oh, just a regular MRI, like my brain or my, thoracic or lumbar, it's usually 20 to 30 minutes. Just try not to get too stressed out. I'm a half glass full person, and I know that I've had anxiety and stuff like that. But if you can get through that thing, then go and treat yourself to like a cheeseburger or whatever afterwards. You know what I mean? So I just thought I'd throw that out there. Yeah, no problem.
Thank you so much. All right. We are going to have a little bit more discussion later. I do want to move it on to a second topic that we just want to make sure we at least talk a little bit about today. So that's the exposure to contrast and, potentially even radiation with imaging. And so I'm going to ask Dr. Ahlawat to just give a really quick overview of what we know about contrast exposure, radiation exposure, and then we can go on with our discussion.
So this is just a short overview, introduction of the concepts, challenges, controversies of radiation and contrast material. So first about the radiation, why do we care? Because there's a link associated with cancer, but that data it comes from people that had therapeutic radiation, occupational radiation, survivors of Nagasaki, Hiroshima. So it doesn't come from diagnostic radiation, which is the domain we're in. And the link with a diagnostic imaging, it's based on mathematical modeling, not data yet. So many tests use ionizing radiation. I'll talk about which ones. But keep in mind that radiologic testing really has a positive impact on patient care. So if you're going to do a test, you should know the reason why it was done. And as radiologists, we're concerned about it. And as ordering physicians, I'm sure Miriam and Amedeo are also thinking about which test to use and how best to use it. So some concepts about radiation, there are a lot of different concepts. Firstly, it's an estimate. Second, you could think about it like walking through rain. So how much rain is falling is really how much radiation you might be exposed to. But that doesn't really matter because it really matters how wet you got in the rain. Was it just a sprinkle or was it a downpour? So that's absorbed dose. And how harmful was the rainwater? That's the type of radiation. So as PET scans were mentioned, those have alpha particles that have different type of radiation versus gamma rays or X-rays that come from a bone scan. So that's the type of water. And ultimately, it doesn't even matter. It matters what happened with that water. Like, were your socks wet or is your lung wet? So that's talking about the tissue specificity. And some tissues are radiosensitive while others aren't. So brain, spinal cord, and muscle are less radiosensitive, while like lymphoid tissue or bone marrow is very high. So we think about those kind of things when we design what test is done and why it's done and how best to use it. And this part, everyone wants to know about, like radiation. On this line is showing you, that's radon. That's how much radiation is in the environment on an annual basis. So that's 2 to 3 millisieverts. That's an estimate. Relative to that, Tests that are low in radiation are like a DEXA scan, bone scan, X-rays. Those are all super, super low. Ones that are higher would be like a PET scan would be considered higher. But even with newer technologies, all of that exposure is decreasing. And also to know there's no threshold known yet that this radiation will lead to this effect with regards to cancer risk. Next, we'll talk about IV contrast. And when we think about IV contrast, there are many things to think about. First, the placement of an IV, which is bothersome for even an adult. So you could imagine if it's a little kid, that's even a bigger problem. If you're going to get contrast or imaging, the need for sedation for someone that may not be able to lie still, for example, in a magnet, or cannot because they're young. So those are all things to think about. With regards to contrast, why give it? Because it helps us see stuff. So this is an image of the cervical spine. This is front, that's back, and we're looking at the cord, and there's some like signal here, and you're like, I don't know what it is. Even a radiologist might think, I don't know what that is. We give contrast, and now we can see that they're like little tumors in the cord. So it helps us see stuff, and that's the purpose of using the contrast. And it may not be necessary all the time. For example, for plexiform neurofibromas, we often don't give it. For spinal cord, intraspinal tumors, it's really useful to give it. So knowing why the test is happening helps us design what we do with it. And there are two types of contrast. For CT imaging, you use an iodinated contrast, while for MRI, it's a gadolinium-based contrast. And here we've done CT imaging, and what it shows us is all these vessels surrounding a tumor. That's really important to know for a surgeon that might be removing that tumor, like, oh, there are vessels on the top of it. So knowing the role and why the imaging was performed helps us design whether to use contrast. And here it was really important. For the most part, iodinated contrast is considered very safe. People have very mild side effects to it. Some may feel warm feeling, a metallic taste, nausea, headache. With iodinated contrast, there is some allergy-like reaction that can range in about 3 in 100 and be mild, or up to 1 in 500 and maybe a little bit more severe. That can be pre-medicated. And as radiologists, we worry most about its impact on kidney function, and we try to monitor that by asking questions about a person's kidney function prior to it. For MRI, we use a gadolinium-based contrast, and here the top images, it's showing us a plexiform tumor. The bottom image is showing us one portion of it that's behaving a little bit differently when the contrast was given, and this tumor ended up coming out, and it was a good thing we took it out. So it helps us see the margins of the tumor, which portion was worrisome to us, etc. Gadolinium is tolerated extremely well, much better than iodinated contrast. Very mild side effects, and the likelihood of allergy is extremely rare. The things as radiologists we worry about is something called nephrogenic systemic fibrosis. That's exceedingly rare now based on how these agents have been modified. And gadolinium retention. So we've seen people that have frequent exams with gadolinium can retain portions of it in their brain, bones, and skin. We don't know what that means, but it's there now and it shouldn't have been there. So we are looking into it, but we don't know what its exact implications are. But for the most part, diagnostic imaging, especially when you have an indication, a reason to perform it, is useful. It is modified as a radiologist to make it as safe as possible. And the benefits tend to outweigh the risks. That's why we do it. So now we can talk about any issues with radiation or contrast or sedation or IV access.
Great. Thank you so much. So I do want to just ask you, Dr. Azizi, one real quick question on this. So as clinicians, a lot of times we're taking these new guidelines and this new information and trying to adapt what we do based on what we're learning. What are some things that you feel like you've done in your practice to try and minimize risk to contrast or to radiation exposure in patients with NF schwannomatosis?
Yeah, so as a pediatric neuro-oncologist, I see patients that get diagnosed with a malignant brain tumor at age 1, 2, 3, and have follow-up scans until we go into transition age 18. And so far, we have never encountered any troubles regarding contrast enhancing media. So just this being said, independent whether NF or not NF. There are data that came out in the last year saying that The contrast signal in optic pathway glioma, for example, does not predict the risk of visual loss. A change in contrast enhancement does not predict potential deterioration in vision. So that for the optic pathway glioma, solely speaking of the optic pathway glioma, contrast enhancement might not be the most important thing, especially in the long-term follow-up. When we want to do MRI without sedation, for example, then we say, okay, we don't put in the needle, so it's easier for the kids to kind of perform the MRI. And we perform a scan, and if we in that scan we see something that we say, well, it might be useful to use contrast enhancing agent, we might repeat the scan later on to do that. There are some data suggesting nowadays that at least for the optic pathway glioma part, contrast enhancing agents might not be necessary at every time.
Wonderful. And then Heather, I just want to see if you have anything you want to add on this topic or anything you want to discuss.
So, talking about, the risks and the benefits, again, it's really talking to your care providers and saying, okay, do I need to have this MRI right now, or can it wait 6 months? Can I go 18 months out instead of a year to maybe start mitigating some risks if I'm nervous about it? I think that helps. And then really just getting an understanding from your doctor and talking to them and saying, what are the risks? Help me to understand them so that way you feel better about the process overall. And I think that will just help you overall in the future if you're feeling better about your tests and the care that you're receiving.
Great, wonderful. And I just want to say one more time that we know that imaging is critical for us to be able to manage patients. And so although, we did just bring up a few topics that have been more so in the media lately than not. I just want to make sure that I stress again that, if your provider says, I'm worried about you and I need to get an MRI or some sort of imaging done, that imaging is very important. And, like Heather said, make sure you talk to your doctor about what is really needed. But we just want to stress that it is safe for you to get the imaging done.
May I add something?
Yeah.
I think what is important for us is to find and to discern risk factors, to see which patients would need more imaging, which patients might need less imaging, as I've been talking about with the risk factors for the MPNST. So I think this is one of the tasks for us in the future as clinical researchers, that we need to identify those risk factors so that we then can counsel better parents and patients. When they come and say, well, can we do the scan later? We might say no, because that and that. Well, it's the decision of the families anyway. So we are just being kind of giving leading the way. But I think this is something that we have to become better at in the future. And maybe some other things like liquid biopsies will come at some point to help us to identify those patients that at a certain point we need an imaging.
Could I say
Yep,
something?
absolutely.
So we, in the same multidisciplinary fashion, we also personalize not just the interval or type of imaging, but within it, the sequences performed, the use of contrast, and modify on a per patient basis, like a peripheral schwannoma that's known and say we want to monitor its growth. We'll do that scan without contrast and make it as short as possible. Or if someone has a cochlear implant, modify the sequences on the radiology end of it. So there's a lot happening in the background to make it as personalized and precise as possible.
Wonderful. Thank you. So we do have, I think, about 7 minutes left. So I want to open up now to everybody in the audience. I saw a question up here, and I think there's some in the back too. So I'm going to go ahead. I guess I'll walk around with a microscope. I also have a lab microphone. Did you want to start, and then I'll move my way back? Oh, perfect. Wonderful. That's great. Sorry.
This is a little tangential, I guess, but is there a risk with sedation? I mean, I'm understanding that there's not really a risk with contrasting, but, and I don't doubt that all of the scans that are, young son has had. I feel like there have been great reasons for those, but is the risk with the sedation actually?
You want this? So sedation is not equal sedation. So in some centers, an MRI is being done with full anesthesia, intubation, ventilation, and in some centers like ours, we give drugs to let the kids sleep during the examination. So it's not, you cannot really compare. Of course, there is a risk that is reduced to a maximum, actually to a minimum, so to speak, sorry, my English, reduced to a minimum, and you have to have the right setting. In our hospital, we perform MRIs of brain and spine on Monday, Wednesdays, and Fridays for a total of 21 sedation slots a week. So there's a lot of experience in doing that. It's all together with neuropediatrics and epileptology and neuro-oncology. So it's all together. So there's a high confidence in the skills of our anesthesiologists. But I would say we have to admit around 2 to 3 children because of vomiting after such a sedation a year. Okay. We had one aspiration pneumonia over the last 20 years that I remember. So he had to stay for 3 days. So.
I've worked at 2 children's centers. We also engage child life to prepare the child at that transitional age from like 5 to 8, where you think, they're ready enough, but you don't know what might happen in a new location. So having them engage with someone with child life can get them prepared for an MRI. And you'll be surprised by how sometimes a very young child manages without sedation, and especially if we can shorten the protocol a little bit. So yeah, our strategy is to minimize it as much as possible, but if not, there are various depths of sedation you can give, where it can be either just an anxiolytic, which sometimes an adult needs also, to deeper levels of sedation.
Yeah, and this is a very important point to really bring patients and kids to have the MRI without sedation. So if you want to look up, we had a program called I'm Ready, like MR inside I'm Ready, and where we could show that around 80% of even more 90% of those kids that we thought would be able to do it with that program could actually then perform the MRI without. There are some kids where exactly he's already 7 years old and he's like an ADHD like that, where it won't work out. But the most important thing is that the parents must think that it's possible to do it, because if they don't believe, we can see that the child would be able to do it. If the parents don't believe in it, it won't happen.
We have time for one last question.
I just have a quick comment.
Okay.
I usually just after the MRI, I just go to the imaging thing. Just give me the images on a disc. Just burn them on a disc right now so I can look at them. I don't have to wait for the report. I can sort of look at it and make a judgment. If then I have something. If I have questions, I go to my doctor and say, "What's this?"
Okay, one last question. I see your hand up.
So this comes from a very naive place, but with all the talk of the full body MRIs right now, I have a 3-year-old daughter. What's the argument against doing the full body MRI just to provide some sort of a baseline and understanding of what's there, what's not there as we progress forward?
If we know about the risk factors for MPNST, so the reason would be to prevent an MPNST from happening or to detect it early. We know that the risk for an MPNST is so low in children. The youngest I've seen was 9. The youngest in literature I've seen was 1, but this is just kind of really kind of extraordinary. But about the possible risk factors. So if a child is affected by those possible risk factors, we do screening earlier than that, as I've shown you with the PET screening in asymptomatic patients. Those were high risk patients. But if there is not a high risk situation, it's so rare to get an MPNST in children, fortunately. Yeah, but still you have to look for the symptoms: rapid growth, novel pain, novel nodule forming, function that is deteriorating. So these are the symptoms why we would do an imaging no matter what the age is. But otherwise, I wouldn't do it.
And I think I just want to add to that. So a big part of it is the lack of medical evidence that doing it at the age of 3 is going to improve on that patient's care moving forward. Now, that being said, as a community, we are looking at this question. And so the NFTCT, the Neurofibromatosis Clinical Trial Consortium, is going to be opening a trial very soon where we're going to actually look at this question. And what we're going to do is we're going to do screening, quote unquote, whole body MRIs in kids between the ages of 0 and I believe the upper ages, maybe it's 1 to 8, but it's basically our young kids who've never had a whole body MRI before or never had imaging done before. We're going to see how many of those patients have a plexiform neurofibroma, the extent of the burden, and if there is a tumor that might potentially cause morbidity in the future, could we use selumetinib or some sort of a MEK inhibitor to prevent that for future morbidity? But I just want to stress this is a clinical trial, meaning that we don't know if this is going to be the better approach to management or if our old approach, which is more waiting till that transition period, would be the better approach. So, I would encourage you, if your child is eligible for that study, once it opens, to definitely talk to your providers about getting them on that trial, because we're trying to enroll like 200 and some kids, and it's going to take a lot of families for us to be able to get to the answer of this question.
Yeah, if we have a chance at some point, we can hear more about it.
Yeah, wonderful. Okay. So I apologize. We are, I believe, a little bit over time or just at time now. So we will come and step outside. If there's anybody else who has questions, comments, or want to say anything, we'll try to be out there for just a few more minutes. Thank you so much for coming. Appreciate it.